Good afternoon, everybody. My name is Karan, and I'm going to wait for the slides to come back up. But until then, I'll talk a little bit about our experience working on a community-based surveillance program in Northwest Syria, or what was formerly known as Northwest Syria, and how we used it to screen internally displaced children for acute malnutrition and under-vaccination. All right, so our community outreach program in Northwest Syria was mainly in northern Idlib, northern Aleppo, and western Aleppo countryside. It was basically a network of 45 community health workers, CHWs, that were operating around 6 PHCs, primary healthcare centers, supported by MSF Spain. Next, please. We were reaching, at its peak, about 54 IDP camps and close to 40,000 individuals. Next. Okay, great. And so the community-based surveillance program ran between 2022 and 2024. All of these CHWs were partner staff, so they were not directly managed by MSF, but they were trained and supervised by MSF staff. The CHWs started with engagement in the communities, introducing themselves. They were members of the community, so they were part of the people that they were working with. Then they went through the usual process of identifying the area that we want to work in, and then move to collecting information on a regular basis. They would use modular Kobo forms using Android tablets. The internet connectivity there was reliable, and we were collecting regular information on a lot of health indicators, including mortality, morbidity, health-seeking behavior, and reproductive health outcomes. An important part of this was also making sure that anybody who needs referrals to healthcare facilities are immediately recommended by the modular form to do so. So the objective of using this system to screen for malnutrition and vaccination was nothing new. We were doing it annually to reproduce rates of under-vaccination for measles and rubella, and also for acute malnutrition. But this year, with the last year, with an increasing downturn in funding, then superseded by USAID funding cuts, there was a sharp decline in accessibility to primary healthcare, but particularly to nutrition services. The vaccination services were still working reliably, but there was no third-party assessment of any coverage. So it was always based on administrative numbers reported by the authorities doing the vaccinations. So we use this program to mainly target children 6 to 59 months age, but also you cannot have healthy kids without healthy women, and so we also wanted to reach to pregnant and breastfeeding women and girls. The methods, we used screening modules on top of the existing community-based surveillance modules. So you can see I've visualized it here. The regular surveillance module is just a bunch of different blocks that ask a lot of different things. We took one block out. We added the nutrition module for the third quarter of 2024. And then for the last quarter, we took that block out and added vaccination coverage at the end. A lot of this was also built around regular follow-up, regular monitoring and evaluation of indicators. And as soon as the CHWs would send us the data by the end of the day or by the end of next day, we would be able to give them real-time feedback on what is missing, how many people are they able to reach, and if they have to reach some people the next week, or so on. And we also train them on how to do the MUAC using a smart survey sort of training methodology, and also on the EPI, the expanded plan for immunization. In Northwest Syria, the expanded plan for immunization was slightly different than what is used in the rest of the world. So it was a bit more challenging to adapt all of these existing standard tools to something that works in our neck of the woods. This is just some screenshots from the Kobo form. If you don't read Arabic like me, you can still see the picture and figure out which vaccine we're talking about. But you can see also at the top right and the bottom right that it recommends you if the child is missing vaccinations, or if it's malnourished, if they're malnourished, and if they need to be referred, where they would be referred. I've blurred out the name of the PHC. But depending on the camp, depending on the location, the module would tell you exactly where to send this child. Of course, in Arabic, the language that CHW spoke. This is just for me. So these are some results. Malnutrition in children. We saw overall GAM rates of about 2.5 to 3.5%. As always, the malnutrition rates in girls were a little bit higher. But these are numbers consistent with what was found in the Global Nutrition Cluster survey in 2023. One thing to note is that we were targeting about 8,000 kids, and we were able to reach over 90% of them. But the only thing we were not happy with is that we weren't sure if they were able to find the nutrition treatment they needed. So we would have liked to do a follow-up, but unfortunately, due to operational constraints, we could not follow up with them if they actually got the treatment they needed. This is just the same numbers for women and girls. You can see we were targeting about 2,900 women. We reached 85% of them, but we could only screen 45, half of them. This is because half of our team is male and couldn't conduct the MOAC, which is a bit more challenging in our context. This was something we were aware of going in, but we still wanted to understand the reach of the program. We could not redistribute the CHWs because they were residents of these camps, so we could not send them to another camp. Nonetheless, we were still able to manage to reach these number of people. And with the all-female team, we could have screened all of them. As you can see, the number under 18, unfortunately, we still have some pregnant girls under 18, and they had the highest rate of malnutrition, actually over 15%, but the rest were lower according to age. Again, we could not do a follow-up women who were referred. This is vaccination. So we learned from our loss to follow-up sort of confirmation gap, and we did try to match that and try to improve on that with the vaccination module that we launched in the last quarter of 2024. We were targeting to reach about 7,700 kids because a few of the kids and a few of the families had left by then, and we were able to reach about 2/3 of those. Overall, the black is the zero-dose children, all of them across all age groups and all gender disaggregation. They were under 5%. And the rest, we were able to confirm by recall and by card. A lot of them were vaccinated entirely according to age, with some gaps for some vaccinations. On your bottom right is a sort of pie chart showing how many children we referred and how many we could confirm. Only 1/3 we could confirm to be vaccinated. 15% of them could not be vaccinated, but the rest, half, we could not follow up on because we did the follow-up in January and February 2025. And if you were following the news, a lot went down in November and December of 2024 in Syria. So you might have noticed I haven't used a lot of pictures from Syria until this point, and that was intentional because all of this was remotely managed from Jordan. Our entire team was based not very far from here, just about 15-minute walk. But we had an incredible team in Syria, and we had an incredible team which was 600 kilometers away from us, which we never met, managing it for us. And there was no supervision team, but they were all trying their best. And they were able to manage this entire program within a span of 6 months. One limitation we did have is there were limited vaccination and nutrition services overall. And as you saw with the funding cuts initially due to USAID, but then also from December onwards, there was even a huge downturn in the number of facilities available because now priorities were changing very rapidly. There were always security challenges with accessibility being quite difficult, not just for us, but our Syrian staff as well. And many times the CHWs were left to manage that themselves. Particularly during the end of November and throughout December, things were not very feasible for people to move around. We stopped the program for about 15 days, but within a week, we got it back up and we were able to finish all of our outreach. So in conclusion, I think this program can be concluded in so many words. There's a lot of words here, but if I will say 4 things, it's fast, it's free, it's feasible, and it's fantastic. Not for us, but for the children and the women and the girls who were trying to get the care they need when they need it and where they need it. And I think that's what I want you to take away from here. Maybe one thing I will conclude with is what the future holds. This is a picture I took on my first ever visit to Syria after the entire program was already defunct. A lot of our camps that we were supporting look like this now. Over 65% of the people have gone back to their places of origin with a lot of hope, with a lot of courage. It's not an easy task to uproot your life for many years after 14 years of conflict and go back home and start it all over again. But they're all doing it. And we're really happy that we had to shut the program down for this reason. But we learned from it, and we're trying our best to use this, adapt it in other ways, using other priorities in other locations that we're now working in. We've used a little bit of this experience in the south of Syria and Daraa as well, and we hope to use it in the future as well. So thank you very much. These are all the wonderful people who have supported this program. Some of them are here with us. But for last and not the least, the people of Northwest Syria, for their resilience, for their inspiration, and for their courage to go through all of this with us and let us into their homes. You can scan the QR code. It's not going to work, so we're going to have to do it old-fashioned way. You can send me a pigeon, or you can come talk to me. Thank you very much.